Okay. So, the state of New Mexico has a statewide communications network over radio. And this allows you from pretty much anywhere in the state to hit one of our EMS repeaters and talk to anywhere else in the state. It is made available to all EMS and public safety agencies. However, when we're communicating as EMTs, we can use a variety of different things. You can, of course, use your cell phone, you can use radios, you can use computers in the field that are selected and set up for mobile data. All of this is designed to move information from one point to another, and that can be patient status information, that can be communication with an MSEP, that can be dispatch information, that can be transmitting data from the ambulance to the hospital, any number of things. Different places along the radio spectrum do different things, and the EMS areas all operate in general around the VHF and UHF areas. So you see kind of these areas, you see right here where it says UHF EMSCOM. This is the part of the radio spectrum where EMS in New Mexico exists. From 462 to 469 megahertz is the frequencies that we use, and we call those med channels. Meds 1 through 122 exist, and those are managed at the federal level, and then the state divides them out as to who gets to use what where. You need to be aware of a concept called a repeater. A repeater is a radio that's placed at a strategic area, usually a high elevation, a roof of a tall building, mountaintops. We have lots of them at 9 Mile Hill and up on the Sandia Crest. And these are locations where a less powerful radio transmits to, and then the repeater retransmits that at a different frequency over a wider area. So ordinarily, I would not be able to use this radio that I'm holding in my hand. I would not be able to talk on this to probably any of your houses unless you lived right near me. However, this radio will absolutely go to the Sandia Crest, and then it would rebroadcast and send it over the entire city, allowing you to reach further distances than you could with just a regular radio. So that is what a repeater is. Here's kind of that diagram. It's up there in a high location, and the base stations can get to it. A portable radio can get to it. Mobile radios in vehicles, ambulances, things like that can all get to it. And then it allows everyone to hear that communication. We're not going to go into detail on any of these things. Just know that there are certain technologies that we use to divide them up. All of the repeater sites in New Mexico have like Med 10 and Med 9 and a lot of these important med channels on them. And to avoid people in different geographic areas hitting multiple repeaters at once, which, just take my word for it, does not work, there are different technologies they employ to only activate certain repeaters at once. And these are called subaudible tones or channel guards or private line PL tones. You don't have to worry about any of that. Just know that they exist on your radios that you'll use in order so that you're only activating the repeater that you want to activate, and so that other people from other geographic areas don't activate yours. The term channel is a term that we use for the radio itself. A channel is something that is programmed into the radio, and it consists of multiple parts. It's the name of it. That's usually what's displayed on a screen, the frequency that it's transmitting on, its PL tone, and then the receive and transmit frequencies. So those all make up the channel. So that's just a point of terminology. All right. So the statewide communication system was developed for this purpose: notification of hospitals for incoming patients, medical direction, hospital diversion as needed, coordination between EMS agencies, ambulances, and aeromedical, and then they're a backup for hospital-to-hospital communication. So in a disaster scenario, all the hospitals have med radios in them, and they can talk to one another if needed. In the state of New Mexico, all EMS units are assigned a call sign. These are assigned by the EMS Bureau, and they identify a specific ambulance. And these are often given out by agency. So for instance, Albuquerque Ambulance, just because I know them the best, their call signs are all 30 and then 2 other digits. So there's 30, and we start with 01 and we go all the way up to 3099 if we needed to. 3100, it would be somebody different. And so those are all given by the EMS Bureau when an ambulance or EMS unit is put into service. This is an FCC requirement when you're talking on the radio. When you are done with your radio transmission, you have to sign off using your call sign that you are given, and those are generally done in single one by agency. So UNM and Albuquerque Ambulance use the call sign KU7891. Again, you don't have to memorize that, but just know that that is something that if you go work in the field, you will have to know. The brain of all of this exists in Santa Fe. So Santa Fe Control is the single link-up point for the entire EMSCOM scenario, the entire EMSCOM system. They are responsible for patching repeaters together, for doing phone calls. They can act as a backup dispatching center. They can assist with mechanical and navigation problems. They can help you get immediate assistance from law enforcement or other agencies that you need for hazmat or poison control. They are the state designated coordination center for disaster response. They dispatch the crisis support team, and most requests for air ambulances go through Santa Fe Control as well. They can also patch radios together, repeaters together, so they can allow somebody in Sierra County, which is way down south in New Mexico, to talk to someone in Los Alamos simply by patching their repeaters together. So they're kind of in control of the entire EMSCOM system. This is a map of all the repeater sites in New Mexico in the EMSCOM system. So you see there's quite a lot. There's more of them up north because the terrain is more mountainous and it requires a higher density of repeaters in order to provide the coverage, as opposed to down south where you tend to have much wider coverage by these repeaters and they don't need quite as many of them down there. So this is the entire EMSCOM system in New Mexico. There are some special considerations for the Albuquerque and Bernalillo County area. Albuquerque Base is the dispatch center for Albuquerque Ambulance, and it is the primary control for all Albuquerque-bound transports. So all radio traffic for Albuquerque area hospitals will come through Albuquerque Base, and those are on Med 2. So if you were working for an ambulance agency that was not in Albuquerque and you were coming in to Albuquerque for a hospital, you would call Albuquerque Base on Med 2, you would say, hey, I need Med Channel 1 for UNM, and they would clear you on that. Albuquerque Base also manages disaster and MCI notifications, and they also manage all transfers and transports and air medical and all of that inside of it as well. The med channels that we use here in Albuquerque, with one exception, this is up to date, but we use all 1 through 22 are used. Now, not every single channel is used, but Med 1 is UNM, Med 2 is out of town, and then different hospital groups have a med channel. So Med 3 is the VA. In Santa Fe, St. Vincent's is on Med 5. All Loveless hospitals here in Albuquerque are on Med 6. All Presbyterian hospitals are on Med 7. Meds 9 and 10 are used for Albuquerque ambulance dispatching. And Med 22 is Sandoval Regional Medical Center up in Rio Rancho. Any questions on the communication system here in New Mexico?
Negative.
At least somebody's still alive. All right. Let's move this along. Believe it or not, we're actually almost done. After this one, we'll take a short break. So, a quick overview of the actual medical scope of practice here in New Mexico. So, what is a scope of practice? A scope of practice is a legal document that identifies all skills and medications that an EMS provider can give in New Mexico. They're drafted by the State Medical Direction Committee, which is the MDC. That doesn't stand for the Metropolitan Detention Center. That stands for the Medical Direction Committee. This scope of practice is drafted and then approved by the Department of Health. And then it is the law that we operate under in terms of what we do, what medications we can give, and what skills we do. So our scope of practice covers all of the levels that I talked about and even provides special accommodation for wilderness certifications. Very, very briefly, an emergency medical dispatcher in their scope of practice is allowed to dispatch and to provide standardized forms and dispatch for sick people, traumatic individuals, and then be able to dispatch the appropriate response. They're also in their scope of practice allowed to give pre-arrival instructions over the phone when it's possible in order to comply with the emergency medical dispatching priority reference system. That's just a thing. You don't have to know any of that because this is not a dispatch course. First responders, this is their scope of practice. So everything over on the left side are things that they do not need medical director approval to do. So everyone, and this is pretty much what everyone can do, right? They can do basic airway management, they can suction, they can do CPR, they can do bleeding control. Now it's interesting that a first responder actually is not authorized to use a tourniquet. Okay, first responders are authorized to use direct pressure just by their regular scope of practice. They can do splinting, they can do spinal immobilization, they're actually allowed, because they have to be allowed to do scene assessment and triage, they are allowed to use the radio system, and they're allowed to give oxygen and help with emergency childbirth. With their medical director approval, they can do positive pressure ventilation, aka a BVM, they can use traction splinting, they can use an AED, and use supraglottic devices. By the way, because I get an audio notification when someone leaves, I take attendance at the beginning and then again at the end, and you have to stay for the whole thing to count, just so you know. All right. So first responders are allowed to give medications through a couple of different routes. All of these require medical director approval. They include nebulizers, sub-Q injections, IM injections, and oral routes. They can give all of those medications listed over there on the right-hand side. We're not going to go over those in detail because this is not a first responder class. The EMT basic scope of practice is bigger. It has all of the things that the first responder does, but it actually specifically allows tourniquet use. Okay, it allows for glucometry and wound management. Okay, those are things that are new. And then with medical director approval, all the same things that the first responder does. To add in a combi tube, they can transport patients that have some special devices, NG tubes, urinary catheters. They can have IVs in them as long as they're not actually running any medications. They can have PEG tubes or other types of vascular devices, like what somebody might have for a shunt if they were going through dialysis. They can also do certain types of point of care testing as long as the state has allowed it under certain circumstances. Okay, so this is what you guys operate under. The medication routes, same thing. The addition that we have as EMT Basics is an intradermal route, which means a skin-based medication if you want to use a patch. We can also give quite a number of new medications. You can use activated charcoal, you can use acetaminophen, you can use ibuprofen as a pain control agent. Okay, you can give Narcan, you can give epinephrine, and you can assist with the patient's own nitroglycerin as long as you have MCEP approval. So those are some additions to the EMT basic scope of practice. Some other medications you can give, EMT basics can give immunization and biological agents as long as they are a part of an actual DOH, not DHS, initiative or some type of emergency response under a physician order. Okay, so you can't just go out and start giving flu shots to people, but you can do that if you're a part of a DOH initiative to like give flu shots to people nationwide. If you're running a flu shot clinic or something, you can do that. Okay. All right, and we're just going to glance at this. The scope of practice for an EMT intermediate doesn't have so much more in the way of skills, but it has more in the medical director skills. EMTIs can do IV, they can do blood draws, they can do IO access, which is in the bone for both pediatric and adult. They can, of course, give medications through an intravenous route, through an intranasal route, okay, through a sublingual route, through the IO, and down a tube if a paramedic has a special, if a paramedic is there or the EMTI has a special skill. Okay. So there's a lot more medications. You don't need to go through all of these or really even know these at this point. Just know that the EMT intermediate scope is much larger. Paramedic is the highest form of license that we have in the state of New Mexico without special skills. Basically, the entire scope of practice is open to a paramedic. We can use a lot of other devices for anti-shock. We can do more skills, especially with medical director approval. We have much more advanced airway. We can do cardiac monitoring. We can do all of these different things, and this is the highest level of EMS license. As you see here, there's a lot more skill and a lot more medication that we can give, to include the funness that is a rectal administered medication. That's loads of fun. All right, so also the medications that we can give are much higher in terms of how many that we have. There's a lot of them out there. Okay. All right. And then very briefly, the wilderness level of care in New Mexico is something that's recognized by the Bureau as being necessary because there are plenty of places in New Mexico where the time to hospital is greater than 2 hours. And this is what the state sees as a wilderness environment. This allows certain things that license levels are not normally able to do, like ceasing CPR. Okay, so if you're in a wilderness environment and you're working a code, you are allowed to cease CPR and declare death. You are allowed to clear the cervical spine injuries, so patients won't have to be backboarded. And then we can reduce dislocations, shoulder, knees, and finger dislocations can be reduced in the field as long as you have adequate training and medical director approval. So those are all things that can be done in a wilderness environment. And if you're working in a wilderness environment, chances are you probably have special skills in place as well. Now, a scope of practice is designed to guide people through what they should do and what things they can and cannot do. But it is an inherently living document that can be edited and modified by the state at any time. Now, there are certain intervals that we go through in order to revise the scope of practice, and those happen every few years. But sometimes there are special situations that arise, and that's why the state has special skill applications. That is why these are guidelines primarily, and not always a hard and fast rule, because sometimes there are special situations that arise. And what this is covering are patients that need a medication that is outside the scope of practice of a field provider, but that the family has. So there are certain types of medications for diabetes, for instance, glucagon, that is outside the scope of care of an EMT basic. But if the family has it for that patient, they can give it, and it's not a scope of practice violation for you to transport that patient. Okay. We talked about special skills before, so I'm not going to go over all of that. The last thing that you need to know about the overall scope of practice is that we are allowed to give over-the-counter medications. We're allowed to distribute them, not administer. We don't recommend that people take them. But if you're working on a standby situation and somebody comes up and like, hey, do you have any, Tylenol? I have a headache. As long as it's in a individual packaging, okay, not a bulk thing. Like we can't just go over to Costco and buy a container of Tylenol to hand out to people. They have to be in individually packaged doses. We can give those out as long as the EMS agency has a physician-approved list of medications that are over-the-counter medications. This isn't something that you're going to encounter very often, but it's something that you should know exists because you may give it, especially if you do stuff like work on a standby at a movie site, if you do any of those kinds of things, ski patrol, those are all things you may encounter that. Okay. We do not administer these medications unless they're actually in our scope of practice. So while you could hand out over-the-counter Tylenol to someone for their headache, as an EMT basic, you couldn't administer that to them. You could not give that to them for administration, say, here, take this, because we only give it as an EMT basic for pediatric fever, right? But you can distribute it. I know it seems kind of pedantic, and it kind of is, but there's a difference between distributing and administration. All right, any questions? All right. Do you guys want to take a break, or do you want me to go through these last two sections?
Keep going.
Going once, going twice.
Let's finish this.
All right, let's finish it. I'm down. Like I said, please do not leave the meeting until I tell you you can leave, because again, I'm taking attendance at the end and comparing them, and if you leave before I do that, you won't receive credit for the time that you were here. All right. Let me get this last one set up, because this is all about pharmacology. Okay. Pharmacology for the EMT basic. All right, so hopefully most of this will be a review from what we have covered in class. Now, I need you guys to wake up. There's going to be some practice problems at the end of this that I want you guys to work through with me on and come up with answers for. Okay, so there's going to be a little bit of very, very basic med dosing practice here at the end. So make sure that you have a piece of paper nearby or something else that you can write with, and some form of calculation device, your phone, your computer, I don't care what it is. Okay, but just make sure you've got one of those handy and nearby. Speaking of which, I will open mine because I'm going to need it. All right. So, pharmacology for the EMT basic. Here's what we're going to cover. How medications are named, what their types of interactions and effects are. We're going to show you how to get to the New Mexico formulary, and then we're going to go through the specific medications for the New Mexico EMT basic. If you want to take a look, these are all listed online. There we go. And the state maintains a drug guideline formulary that covers all license levels. So let's define some terms. Pharmacokinetics is a study of how a drug is absorbed and distributed through the body. This is called biotranslocation. The study of how the drug actually alters the body and then what changes under what happened to that drug afterward is called biotransformation. And this has to do with how the drug is metabolized and what steps it goes through before it is stored or eliminated from the body. Medications have multiple names. Okay, the very first name that is given to a drug is what's called its chemical name. This is the exact description of the chemical structure, and it is very standardized in organic chemistry. This is where you'll see these big long things like 3-dihydro 1-methyl 5-phenyl 2H1. Okay, that is a specific chemical name for a medication. All right, it is then filed under an official name. This is where it's called in the USP, the US Pharmacopedia. And then there are trade names and generic names. When a drug manufacturer develops a drug and they register it with the US Patent Office, they are given a 17-year exclusive right to produce a drug under that name. Okay, so this is to allow a drug company to recoup costs because developing a new medication takes many, many, many millions of dollars, sometimes hundreds of millions or even billions of dollars, depending on the type of medication that it is. And by granting the manufacturer 17 years of exclusive rights, this allows them to sell that medication and be the only one to sell it and make it so that they can recoup the costs that they invested into that development. After that 17 years is up, anybody else can start making that drug that wants to. There are other generics of medications that may be the same thing but only slightly different. They can be manufactured. They're often cheaper. So most of the time, if you go to your doctor's office and they give you a prescription, most of the time insurance is going to prefer to cover the generic instead of the trade drug because under most circumstances, they're identical. Now, there are exceptions to this, but for the most part, they are identical. This is why you can go to the pharmacy and you can buy Sudafed brand Sudafed. Or you can buy the Walmart brand, which is pseudoephedrine, which is the name of the drug, and it's sometimes way cheaper than buying the trade or name brand. So we need to know about a couple of different types of medication interactions. These occur when 2 or more drugs are taken and they interact with one another. They can increase, decrease, or cancel out the effects altogether. Synergism, I know we covered this, is where 2 drugs work together to amplify their effects. Okay, this is an example of like giving epi and albuterol together to relieve asthma. Potentiation is where one drug prolongs or multiplies the effect of another drug. And then antagonism is where a drug prevents reception of that drug. Narcan is an example of an opiate antagonist. Of course, there are different effects of the medications. The 2 broad categories that you need to know are therapeutic effects. This is what is the drug designed to do? What is it supposed to do? What do we want it to do? Okay, nitroglycerin is supposed to cause vasodilation, which is supposed to reduce workload on the heart, which causes pain relief. Okay, albuterol, supposed to be a bronchodilator. However, medications also have other non-desirable or non-therapeutic effects that we call side effects. For instance, a side effect of the vasodilatory properties of nitroglycerin is that it causes a headache. Okay, it can also cause low blood pressure or hypotension. Same thing with albuterol. Albuterol causes you to be tachycardic and nervous and have tremors. These are side effects of medications. They often go right along with the therapeutic effects. Of course, the ones that we never want to have are toxic effects, right? These are harmful interactions of a drug and the patient. They can be life-threatening, they can be what's called idiosyncratic, or they can be allergic reactions, toxic effects. And these can be produced or brought up to noticeable levels by overdosing. Okay, if you overdose on certain medications, you'll see toxic effects, whereas if you stay in the therapeutic range, you won't see those toxic effects. An example of this is aspirin, right? A toxic effect of aspirin can be a GI bleed, and this can lead to shock. So, hopefully we all know these terms: the dose, indication, contraindication, mechanism of action. You need to know about relative and absolute contraindications. A relative contraindication is something that just increases the risk of a drug. So the example that I have here is nitroglycerin. Nitro has a relative contraindication of a marginal blood pressure. So somebody that has a blood pressure of like 90 to 100, we should be careful with giving them nitro because it could cause low blood pressure. But an absolute contraindication is something that would prohibit the use of that medication altogether. So like an allergy to a medication or someone that has known issues and known toxic side effects, that could be an absolute contraindication. All right, people can always be allergic to pretty much anything, right? Common allergens are listed here: antibiotics, various narcotic analgesics, aspirin, and sulfa-based drugs. Now, this last category can be quite large. There are a lot of different sulfa-based drugs, things that might surprise you. So just know that as you go through the medication formulary, you will see contraindications listed for sulfa allergy when maybe it's not super clear that this was a sulfa-based drug. So here is the formulary for the EMT basic, okay? Acetaminophen, charcoal, albuterol, aspirin, epi, ibuprofen, ipratropium, the 2-PAM or Mark I auto-injector kits, Narcan, nitroglycerin, and oral glucose. So let's look at each one of these. Tylenol, or acetaminophen, also called APAP, is a antipyretic and analgesic medication that is given for febrile pediatric patients with an extended transport. Okay, the EMT basic is allowed to give this orally at a dose of 10 to 15 milligrams per kilogram. Now, you should go look in the state formulary because there is a maximum dose that is listed. A patient should have no more than 50 milligrams per kilogram in a 20-hour period. You see there are some absolute contraindications here. If somebody has an allergy to Tylenol, they shouldn't get it. And if they have liver disease, they shouldn't get it because Tylenol is metabolized in the liver. The formulary also lists some common side effects, which for acetaminophen is a rash, and lists any toxic effects that might be there. So for acetaminophen, the only toxic effect is people that have liver disease or if you have a major overdose, because that will destroy your liver. Any questions on Tylenol? All right. Activated charcoal. I know we've talked about this. It is an adsorbent. It's not absorbent, adsorbent. That is marketed under many different names. All that you need to know is it's given for absorbable poisons. Okay, we give this orally with a dose of 60 to 100 grams for an adult or 30 to 60 grams for a pediatric. It is contraindicated for some specific agents that is covered in your book and under the toxicology area, so I'm not going to belabor that point. It can have common side effects of nausea because it's nasty and constipation. Okay, there can also be some toxic effects like bowel obstruction or aspiration that might occur if somebody vomits and then inhales it. So we always have to balance the risk versus benefit for any medication. Albuterol is one that most of you are familiar with. We all had these in the various standardized assessments. This is marketed under many different medication names: Ventolin, Proventil, Albuterol, Flovent. All those different things can mean the same medication. It is a beta 2 agonist, which means it works as a bronchodilator. It is given for wheezing, for asthma, for COPD through an inhalation route, usually nebulized. For an adult, which is what we're giving it for, it's 2.5 to 5 milligrams up to 3 mLs of saline that are mixed in there. Okay? Of course, there are contraindications for it, whether or not somebody has an allergy or they have already taken other beta 2 agonists. Common side effects include tremors, headache, and an increase in heart rate. There are some toxic effects that can be seen in it, including something called paradoxical bronchospasm. This is where the lungs will actually clamp back down again at certain dosages of albuterol, but you generally won't see those in the dosages that we are giving them in EMS. Aspirin. Aspirin was originally a drug that was owned by Bayer. They had rights to produce it for 17 years, and that has long expired, and you can find aspirin through many different routes. The picture that we have up here is actually a Costco brand of aspirin. We give it as usually baby chewable tablets, and those are 81 milligrams a piece. Our dose for that is 81 to 325. And anybody remember what the indications are for that? Wake up, people. Look at your screen. Oh, I had a
Chest pain.
there we go. Cardiac chest pain. Okay, good. Good, good, good. So it is classified as an analgesic. It is an antipyretic and an anti-inflammatory medication. It also, and the reason that we give it in chest pain is it's also an antiplatelet medication. It helps deter the aggregation of platelets in blood so that it doesn't clot quite as much. And that's especially useful to people that are actually having heart attacks. Fun fact here, toxic effects of this can include a hemorrhage, usually GI bleed, and tinnitus, which is that ringing in the ears. All right. Epinephrine, something very special to New Mexico for EMT basics. Trade name of this is adrenaline. This is also what adrenaline in your body is. It is epinephrine. It is given for status asthmaticus or asthma extremis, same thing, or anaphylaxis. Okay, for an EMT basic, you must attempt to contact online medical control, and you can only administer it either in an auto injector or in a 0.3 ml syringe. Okay? So remember that. We give it through a sub-Q or IM injection, and its contraindications include hypertensive crisis or active pulmonary edema. You would not give this under those circumstances. All right, ibuprofen is something that is in the scope of practice for EMT basics. You can give this in both pediatrics and adults to treat fever or pain only, never both at the same time. All right. The trade name for ibuprofen is Advil. It is an NSAID medication, a non-steroidal anti-inflammatory drug. Again, we give it for fever or analgesia through a PO route, which means they're given a pill, they have to swallow it, or it's a liquid that they will drink in that way. For an adult, it's 200 to 400 milligrams. For a pediatric, it's a weight-based dose of 10 milligrams per kilogram. All right. There are more contraindications for this, and this is kind of the same for any NSAID medication. Anyone having a heart attack or that has an active GI bleed should not receive an NSAID medication. Anybody that has an allergy to NSAIDs or some other type of hypersensitivity. Ipratropium bromide, also called Atrovent, is a medication that is usually given in conjunction with albuterol. It is an anticholinergic. So albuterol relaxes your bronchial passages, but ipratropium bromide or Atrovent causes the secretions to dry up. So that's one of the big things in an asthma attack, is that not only do the bronchioles constrict, but they start overproducing mucus. And so albuterol relaxes the smooth passageways, but ipratropium dries out that mucus. And when together, they act synergistically to provide a more powerful, more potent medication effect than they would all by themselves. We give this in 500 micrograms for adults or 0.5 milligrams for adults or 250 micrograms for pediatrics or 0.25 for pediatrics. All right. Contraindications include not only an allergy to it itself, but people with a hypersensitivity to atropine should also not take it as well. All right, so this is the Mark 1 or the 2 PAM injections. This is an antidote kit that is used for various forms of toxic exposures under the SLUGM acronym. So organophosphate and nerve agent exposures are the primary ones that you'll see. So the auto-injector actually contains two medications. One is atropine, which is an anticholinesterase inhibitor. The other is Tupam or proldoxamine. That is a cholinesterase reactivator. So all of that to say, we give this for nerve agent exposures that have SLUGM signs and symptoms. We give it as an auto injection, and that's pretty much it. You don't need to memorize the dosages here because they're going to be in the auto injector. But in case you're curious, it's 2 milligrams of atropine and 600 milligrams of Tupam. Narcan. Narcan is one that is in a lot of public eye because it is the opiate reversal agent. Narcan is nice because it can be given pretty much by anybody with very little in the way of side effects. I know we have nausea, agitation listed here, and dysrhythmias and hypertension listed, but those are really rare. When somebody takes Narcan, and usually it's ignored because the benefit of taking Narcan to a patient who has overdosed really outweighs the potential risk, right? If they don't get Narcan, they're going to die. It is a narcotic antagonist, specifically an opiate antagonist. It is given for opiate-induced respiratory depression through a sub-Q, IM, or intranasal route. You can give up to 2 milligrams of this. Generally, we give it through a shot route in increments of 0.4 milligrams. Or if you're going to give it through the nose, generally you're going to administer 1 milligram per nair, so 1 milligram per side of the nose. It's worth noting here in New Mexico that naloxone has been made an over-the-counter medication, so you can actually go to a pharmacy and buy nasal sprays of Narcan, should you so desire. They're not cheap. When last I checked, about a year and a half ago, they were $130 a dose, I believe. So it's, but they contain 4 milligrams of of Narcan, so it's quite a lot there. All right, nitroglycerin is given for cardiac chest pain, given for ischemic chest pain or angina. However, as an EMT basic, you must have online MSEP or a written standing order, and you must be using the patient's medication, right? A paramedic can give nitroglycerin out of his stock, but as an EMT basic, you can only assist with a patient's own nitro with online MSEP, all right? The dose for nitroglycerin is 0.4 milligrams in either tablet or spray form, and you can give this up to 3 times. You have to be careful with this, especially with borderline blood pressures, because it can cause hypotension. So if somebody is already hypotensive, that will just make it worse. Somebody that has an increase in intracranial pressure also should not be given nitroglycerin. Oral glucose is a just basically oral sugar. Okay, it's 15 grams in a tube. You can give that up to 3 times for altered mentation that is suspected to be because of glucose, or you have identified it as somebody being low blood sugar, and you give that to them, but they have to have an intact gag reflex. Do not give anything to a patient by mouth if they do not have an intact reflex or cannot protect their own airway and swallow appropriately. All right, so that's all of our medications. So when you're going to give medications, make sure that you're practicing good technique. Make sure everything stays clean and aseptic, even if you're just handing someone a pill. Make sure that if you're using a needle or other form of sharp, you are disposing of it properly in a sharps container, okay? These should never be, stuck into the bench seat or something like that, or just left or put in the trash. That can be a big danger. Know the routes of all and dosages of all the drugs that are in your scope of practice, and if you make a mistake, own it. Okay, I have made a medication mistake. I once gave a patient over 3 times the dose of epinephrine for an allergic reaction than what they needed. Okay, it can happen to anyone, but you have to take responsibility and immediately report it to the MSEP or the physician that you're handing off to, so that if there are any adverse reactions that happen, they can know in advance and take steps to help mitigate that. All right, so this is where we're going to do a little bit of practice. So we're going to cover these topics, and then I'm going to work you through some examples to just see how this works. So know your drug dosages, know how much you're going to administer, and then especially important, these two things. Know the standard method of calculating a child's weight when it's not given to you, which is their age in years times 2 plus 8. So if you have a 4-year-old, how much are we going to say that they're going to weigh in kilos if they're 4 years old?
16.
Very good. Let me catch up. I missed something from Al here. She says, even though we can give baby aspirin, are we able to give it to peds, or does the dose? Yeah, so aspirin is generally not given to kids. The term baby is just referring to the dose and the size and the fact that it's chewable. I'm sorry I didn't see your question earlier, Al, but that's what it's not, because it's for babies. It's the size and the dose of it. And yes, so a 4-year-old male, so 4 times 2 is 8, 8 plus 8 is 16. For drug dosage calculation reasons, the standard weight of a child is going to be approximately, 4 years old, is going to be approximately 16 kilograms. Now, you have to make sure that you are applying this in a good way, right? If there is a largely overweight child, that may throw off what your weight calculation is. What this is giving you their ideal body weight. So age times 2 plus 8 will be their weight in kilograms for a child. Then, equally as important is how you convert between pounds and kilograms. So 1 kilo is 2.2 pounds. All right. The way that we always did it in the field is we just divide their weight in pounds by 2, and that gets you an approximate. In fact, it gives you a little bit lower than what it would be. So a patient that weighs 120 pounds, how much would we approximately say that this adult weighs in kilos if they weigh 120 pounds? Yeah, approximately 60. So we just divide it by 2. Now, we actually can get a specific one. If somebody happens to weigh 220 pounds, that's 100 kilos. Okay. Now, it's important to know this because we dose medications in EMS by kilograms. Okay, we're in the metric system. We use milligrams, and the weight is done milligrams per kilogram. So you need to know how to do this. Know that units at the back of a medication do not necessarily mean the same thing. So milligrams and milliliters are not interchangeable. Okay, depending on the concentration of a medication, 1 ml might be 1 milligram. Okay, like epinephrine is, IM epinephrine anyway, is commonly packaged in 1 milligram in 1 ml, but they are not interchangeable. Okay, a milligram and a milliliter, not the same thing. One is a unit of volume, the other is a unit of mass. However, a milliliter is a cubic centimeter, or a cc. So 1 ml does equal 1 cc. They are the same thing, just different names. Alina asked the question: if a child is more overweight, do you give them a little bit more of the medication, or do you just stick with the average? So that is actually, it depends, because, and this is where knowledge of pharmacology comes in handy, because certain medications are what we call fat soluble, and so they will be dosed off of the actual body weight of the child. Some medications are not fat soluble, and they are dosed at the ideal body weight of the child. In general, we are not going to increase the dosage for an overweight child. Okay, we are not going to give them more if you have a kid that's fat, because most of the medications that we are giving in EMS are not fat soluble, and so we could actually overdose them if we give them more. So we're always going to stick with what our standard dose is. Now, if it's done in weight, this is why you will see maximum amounts given for medications. Tylenol is a good example of this. It has a maximum medication, has a maximum dose of 50 milligrams per kilogram in 24 hours. And in fact, most of these, if you actually go and look at our formulary, for epinephrine, for instance, for a paramedic, you will see a weight-based dosage in there for children, for IM administration, for a allergic reaction. But it will say it said whatever milligrams per kilogram, 0.01 milligrams per kilogram, to a maximum of 0.3 mLs. So you're never going to exceed the adult dose. Does that make sense? Hearing nothing, I'm going to assume it makes sense. That's why, like I said, I haven't done huge detail on all of these in here. You need to consult your formulation and whatever local protocol you're going to be working under. But this is just the basics. All right. So how do we do these calculations? Well, the first thing is we need to decide and determine how much of a medication that we are going to administer. So you need to know your dose first. Secondly, you need to know what formulation does your medication come in, okay? What concentration is it? From there, you will decide what volume of medication you will give. You will do all of the 5 rights of medication administration, and then you'll administer it. So for example, if you want to give 0.8 milligrams of Narcan, and your Narcan comes in 0.4 milligram per cc, okay, which is the volume, then you would multiply first you would do a division. You would do what you want, the dose that you want, over the dose that you have, times the volume that it comes in. And I will work an example of this live for you guys to see, okay? It's really, really basic math, but it can get confusing with certain medications, okay? So let's actually do some of these. I am now going to share a different screen. Stand by. All right. Can you guys now see my iPad screen? Cool. All right. So let's pull up our first problem. Sorry, moving stuff out of the way because my screen is now being taken up by my iPad. All right. So this is where you need to have something to write with. All right, so we have a 3-year-old female with a long transport time. We're going to say it's about 40 minutes. Okay. All right, so what drug are we going to give this patient and why? One person has responded. Okay, yeah, we're going to be giving Tylenol. Yes, they have a fever. Yes, we have a 3-year-old with a fever. There we go. 3-year-old with a fever. All right, so what is our dose for her of Tylenol going to be? Give me a second, Ian, and I will see if I can unlock this here for you. Okay, yeah, and it should be unlocked so that you can join back in, but please do. All right, so I'm getting a lot of different stuff. This is, okay, yes, okay, that is the dose that we're going to give. So how much are we going to give this? Let's say that we're going to do 10 milligrams per kilogram, okay? Let's just make this easy. Somebody give me the dose. You have a 3-year-old that you're going to give 10 milligrams per kilo to. So somebody give me the dose. Okay, so we are going to give Tylenol. Our dose is 10 milligrams per kilogram. All right, looks like Yen is back in, so let's lock this again. All right, so we know what we're going to give. We know our dose, which for this 3-year-old, so we're going to do her age in years times 2 plus 8. So this is 6 plus 8, which equals what now? There you go, thank you. Making sure everybody's awake, okay? So we're gonna say this patient weighs 14 kilograms, all right? So our dose is 10 milligrams per kilogram. So we are going to multiply her weight by the dose, all right? Our units cancel. We do the multiplication, and this gives us 140 milligrams. This is what we want to give. Okay. All right, so that's cool. But now we need to determine how much are we going to draw up. So if I tell you that your medication comes in a vial that is 160 milligrams in 5 milliliters. You want to draw up 140 milligrams. How much of it are you going to draw up? You should get a volume out of this. Okay. Emily typed in an answer. Guys, actually do this, please. Get the practice. Okay. A couple answers in. So let me walk you through how you're going to do it, in case you're confused. All right, so our general overall way of how to draw up a medication is what we want, the dose that we want, over the dose that we have, multiplied by the volume that it comes in, okay? So what number do we want? Okay, we want 140 milligrams. Thank you, Emily, for giving me units. Guys, get in the habit now of putting units on, because you know, think about when you're in your chemistry classes or something like that. Units are important. So we want 140 milligrams. All right. Now, what do we have? Okay, we have 160 milligrams in 5 ml. Now, this is why units are important, okay? This, if you don't list your units correctly, this can prevent you from noticing a medication error. For example, if you got the formula mixed up, let's say you put volume on the bottom, what wouldn't happen here, okay, what would not happen here is that these units would not cancel, right? So at the moment, our milligrams cancel and we're left with milliliters, which is what we want. It's a volume, okay? So you're going to do 140 divided by 160, which gives you a decimal, and then you're going to multiply that by 5, okay? And this gets you 4.375 milliliters. Now, your 5 ml syringe or your 10 ml syringe that you're going to use for this is not going to be that finely graduated. So it is perfectly acceptable to do applicable rounding. So the actual dose that I would give for this patient is 4.4. That looks terrible. Is 4.4 milliliters. Okay. Either one of those are acceptable. It's just really, really, really difficult to draw up 0.375 of an ml. Okay, so that's how you do this. All right, let's work another one. All right, and then I'm going to give you guys the information, and then I want you guys to come up with your dose and send it in a chat to me privately so that everybody has a chance to work up on this. Okay, so you have an order to give 0.8 milligrams of Narcan IM. All right. So there's an opiate OD. Your protocol says 0.08 milligrams. Here is your Narcan box. And it is 0.4 milligrams. All right. How much are you going to drop? Answers are rolling in. Seeing pretty much correct answers here. Okay. So keep typing those in if you need me to. I do want to address, no, Grace, what we want is this. Okay, this is what you want to give. Okay, this is what your packaging comes in. This one's pretty straightforward. I know probably a handful of you guys went through the entire math for it, which is great. Thank you for doing that. I want to show you that, and hopefully once you look at this will make sense, that the packaging that it comes in is actually exactly half of what you want to give. So you're going to give 2 times what it is, which is why you're going to give 2 cc. So you want, oh, that's the wrong thing. You want over half times volume. So we want 0.8. We have 0.4 in 1. All right. So fortunately, multiplying something by 1 doesn't do anything for us. So this really comes down to 0.8 divided by 0.4, which equals 2. But because we've got a unit here of milligrams and milliliters, our milligrams cancel, and we are left with 2 times 1 ml, which equals 2 milliliters, or CC. Now, because a milliliter and a cubic centimeter are the same thing. Now, I want to clarify one thing that I saw come in on someone's answer. Somebody gave me the answer of 2 milligrams per cc. Okay, that is not a dose, that is a concentration. Okay, so your 2 milligrams and 2 cc are not the same thing. All right, so this is a concentration. This is something that Narcan could come in, right? We could say that this Narcan came in 2 milligrams per cc, and then you would give a fraction of a cc. But if you come up with a dose of 2 milligrams per cc, none of this is correct, because we are not giving 2 milligrams, we are giving 0.8 milligrams, okay? We are giving 2 cc's, 2 mLs, not 2 milligrams per cc. Okay, that would not be correct. All right, we're going to do one more, and then we're going to be done. All right, so let's go back up here. All right. So here's our situation. You have a 5-year-old male with a fever. All right. Your transport time is 1 hour. Here is the information that I want you to give me when you type back, and I want you to do it in this order. So 1, what medication and why? 2, what dose? I know this one comes in a range. You can use just use one spot for that. I mean, it doesn't really matter. I can do math. Okay, what dose are you going to give? Okay, and one at a time here. I'm going to list all of these out, and then you can send them all to me at once, just so I don't have millions of chat things going through. Okay. Okay, and then 3, what amount? Okay, I will give you in advance this. And we will say okay, so you have Tylenol in 140 milligrams in 10 cc's, because we all know that this is Tylenol. So I want you to do this, send me your answers, then we will work through it. So in your chat, put 1 and then your answer, put 2 and then your answer, and then 3 and then all in one chat message, please. type of package coming. So Grace, good question. So what dose? So basically, how much medication do you want to give? And then the amount would also be what volume. Okay. So how much are you going to draw up from this container of Tylenol? Good correction, Cassidy. All right, so a lot of you have sent stuff in, so let's work through this. All right, so we are going to give Tylenol for pediatric fever, okay? Our dose is going to be 10 milligrams per kilogram. So we have a patient that I said was a 5-year-old male. So our weight is age in years times 2 plus 8. So it actually looks like this, which gives us 18 kilograms. All right. We're going to multiply this by 10 milligrams per kilogram. Our units cancel, and we're left with 180 milligrams as our dose. Okay. That is how much we want to give this patient. All right. So then we have to decide what volume are we going to draw up? What amount are we going to pull? So we have want over have times volume. So we want 180 milligrams. That's, why did I do that? There we go. We want 180 milligrams. We have 140 milligrams in 10 cc's. So our math looks like this. 180 divided by 140 times 10. Okay, make sure we have our units. Right? And again, I'm doing this on purpose. We can freely change between cc and ml. Okay, doesn't matter. They're both measuring the same thing. All right, so then this is where we come over to our handy calculator and we do 180 divided by 140. Okay, so this is where some of you went wrong a little bit. A couple of you forgot to multiply by 10, because what we have here, we wind up with 140 or 180 divided by 140 is 1.2857, so on. Okay, times 10. I did 10 on purpose because that makes the math way easier. I didn't put a unit here, okay, because our units canceled. So when we multiply this by 10, we're moving the decimal. All right. So when we multiply this by 10, we get the dose that most of you got, which is exactly 12.857 7142857142865, 7142886. Okay, that's where the calculator stopped. Doesn't matter. We're going to round this to something a little bit more manageable. Those of you that said 12.85, you rounded a little bit differently. That's okay. Could be 12.86 based upon what I did, depending on how many you're going out to. But I'm going to say that my dose is going to be 13 ml. Now, you could do this same math and actually figure out how much you're going to wind up giving them. But we're not going to. This is going to just give us our basic thing. This is going to wind up being ever so slightly more than our 180 milligram dose, but not by a significant amount. Okay. Does this make sense? Even though we're all typing it, does the way that I'm doing this and actually showing it and writing it out, does that help you understand kind of where this math comes from? Okay. If you get nothing more out of this, I want you to remember that your formulation for medication is want, the amount you want, over the amount you have times the volume it comes in. Okay. This is the cardinal equation for medication administration. And yes, Alina, at 1 milliliter and 1 cubic centimeter are the same thing, which is what CC is. That's cubic centimeter. Okay. Somebody asked me, do we do this on scene? Do you have enough practice to do it quickly on scene? The answer is yes, to both, because most of the medications that we stock ambulances with are a standard concentration. Okay, so a more advanced way of doing this, in fact, the hardest way that we do this, and if anybody here goes to intermediate or become a paramedic, goes to nursing school or something like that, you will have to do drip calculations for IV medications. This is where it gets tricky, because then you have to calculate not only how much you injecting into a bag, but then what is my drip rate. The reality is a lot of medications you start getting a feel for, right? So in the field in Albuquerque, we're giving ketamine, right, in a certain weight-based dose up to a maximum of 25 milligrams. So I know that based off a patient's weight about how much I'm going to give, and I'm going to hit my max dose. But in reality, in real life, we use a calculator or an app. Hippocrates is a great one that has a medication dosage calculator, that all you do is you plug in this information. You say, what is my dose? And you have to know your dose. So you might say that the dose is 10 milligrams per kilogram. You'll put in the weight of the patient, and then you'll put in the concentration that you have, and it does the math for you. Both are necessary, because if you are able to do a mental calculation and say, okay, my dose is going to be somewhere in this range, it's going to be somewhere between, like for this case, what we could say is, okay, I know my dose is 180 milligrams, okay, and my packaging is 140 and 10 cc. So if I come up with an answer in my math that's less than 10 cc, I know I did something right. I'm sorry, something wrong. Because if it's less than 10 cc, it's going to be less than 140. If it's less, I'm gesturing on my screen, and that's not right. If I came up with an answer like some of you guys did that was less than 10 cc, this doesn't pass my initial mental check, because if it's less than what it's packaged in, the dose is less than I want. So if it's less than 10 cc, it's going to be less than 140 milligrams, which isn't right, which means I missed a step somewhere. Same thing, that if you're using an app to do that and you come up with an answer that doesn't seem right, that doesn't make sense, you know you probably put something in incorrectly. So yes, the answer is we have to do this on scene because we have to come up with our correct dosages to give people. And you do come up with enough practice for most of these to do it quickly. And if you encounter a medication that you're not familiar with that you're having to give, say you go on to, paramedic or something like that, that's when you would use an app or a calculator to do the math for you, because it's important to get it right. All right, any questions, guys?
I have a question.
Okay.
So I'm mailing off my clinical book today. It should get to the office by Friday, right?
Oh yeah. And so the clinical books don't have to be in by Friday. I would highly suggest you that if you can, you do that, but I will simply approve them as they come in. What has to be to me by Friday are your ICS certificates, okay? Please don't just send the links to them, all right? Please download them and then attach them to the emails named appropriately, so that my program will categorize them and catalog them appropriately. Okay.
How do we do the ICS certificates? Because I never got an email.
Then did you sign up for an account with FEMA?
No.
Okay. You need to Autumn, we're basically done here. Let me answer these questions. In fact, let me take my second attendance right now, and then I will answer all the questions that you want. But once I take this attendance, you guys will be able to go at your leisure. But let me take this attendance first. Please don't leave. I would hate for you to have to come back and do this. Almost done. Okay, I have recorded attendance. You guys are free to go until you have questions, and I can walk you through this. Let me pull up the FEMA stuff. All right, let me share my screen for you, and we will walk through this. All right, so here in Moodle, you have the, did I share the right one? Share that one. All right, can you see my web browser, guys? And whoever is, I didn't catch who was asking me that question, so. Yes, no, maybe so?
Yes.
Okay, cool. So ICS courses, go to the FEMA site. All right. So we need to take ICS 100. We're going to take this course. Okay, so you can take this course. Cool, cool, cool. All right. So you need to take final exam here.
Okay.
And you need a FEMA SID, and it says if you don't have one, you can register for one here. Okay, and it's going to say, yes, I'm leaving, that's fine. Then you will register for a FEMA SID.
Mm-hmm.
And you'll go through this process of filling out this stuff.
Yeah.
Creating an account. The main important thing here is that the email that you use needs to be something that you're going to check. I know it says work email, but you don't have a work email. That's okay. Just put in your primary email address. Okay. Once you have this, you will get, you'll be able to see in your account your FEMA SID number. Once you have that, you can take the exam online. Okay. Then you will put your SID in here, and then the last name that you used when you are when you registered for that. Okay. Make sure this information is correct both here and when you're registering for the. Probably didn't show you this because it came up as a pop-up window. But open this in a new tab. Okay. Now can you see this? This is the consent for the final exam. Yoo-hoo!
Yeah, I got it.
Okay, cool. So then this is where you would fill all that information in, you would agree, and then you would take the exam, okay? Then it will email you for each one of these that you take. It will send you an email with a link to download your certificate. Download it not only for your records, and then name it with your last name dash the ICS number. So, you know, mine would be bland dash ICS 100. Then once you have all 4 of those, attach them to an email and send them to me.
All right.
Okay, does that make sense?
Got it.
Any other questions, folks?
This is completely off topic, but are we getting like courts for graduation or no? Like